Hello, everyone, and welcome to Echo Asthma Bootcamp, Module 3. Today we're going to talk about endotypes and biomarkers in severe asthma. I'm Ashley, I'm your facilitator. I'm joined by my coordinator, Rachel, and our wonderful hub team, Dr. Mandeep Jassal and Andrea Jansen, certified asthma educator.
Hi, everyone.
Alrighty, thanks to everyone who just joined us. Now we're going to get started with our lecture on endotypes and biomarkers of severe asthma, hosted by Dr. Kerr.
So in today's session, we'll talk about endotypes of severe asthma and biomarkers for severe asthma. So this is where we ended off the last session. The reason to recognize your patient's phenotype is to really attempt to use the phenotype to understand the underlying pathobiologic mechanism or the endotype that would then allow us to select appropriate treatment. And the way we do this in severe asthma is by using a biomarker. And so there are two main inflammatory pathways or endotypes that exist in severe asthma patients. There are two distinct pathways, type 2 pathway and the non-type 2 inflammatory pathway. And it's really important to differentiate between these two because as of mid-2020, biologic medications are approved only to target the type 2 pathway of asthma. And biomarkers can be often used to establish a baseline, guide an appropriate choice of treatment for these patients, and in some occasions monitor progress to see how they respond to the drug. Before we jump on to biomarkers, let's talk about inflammation in severe asthma. Type 2 inflammation is represented on the left side of the screen. Allergens and antigens is what often triggers the cascade. Thymic stromal lymphopoietin, or TSLP, is one of the early regulatory mediators that stimulate the Th2 cascade. The Th2 cell produces interleukins 4, 5, and 13. IL-4 triggers then the B cells to produce immunoglobulin E and ultimately triggers the mast cell for production of other substances downstream, such as histamine, leukotrienes, prostaglandins, and other interleukins. IL-5 is extremely important for eosinophil stimulation and sustenance. And a lot of the inflammation we see in type 2 asthma or type 2 inflammatory asthma is associated with this eosinophilic inflammation. On the right side of the screen is non-type 2 inflammation. This often gets triggered by exposures to irritants, pollutants, microbes such as bacteria or viruses that creates a series of downstream cascade that triggers the Th17 and the Th1 cells to produce additional molecules. Ultimately, the common pathway for both type 2 and non-type 2 inflammation triggers asthma and causes hyperresponsiveness, remodeling, a lot of mucus production, and smooth muscle hypertrophy or constriction, which is ultimately what happens in asthma to cause symptoms. What you see here are the different phenotypes and different inflammatory cascades. On the y-axis is the severity, and the x-axis is the age of onset. If you look at the bubble of type 2 asthma or Th2 asthma, these can be both mild asthma, such as exercise-induced bronchospasm, or it can be quite severe type 2 asthma, such as aspirin-related disease, late-onset eosinophilic asthma, or certain types of allergic asthma. Most non-type 2 asthma, however, tends to be adult onset and more likely to be associated with obesity. Late onset, particularly in women, can be associated with smoking, in which case it's more neutrophilic, as well as this concept of paucigranulocytic or non-inflammatory asthma. So let's review the main points about how to differentiate type 2 or Th2 high asthma from non-type 2 or Th2 low asthma. Type 2 asthma tends to have a lot of airway and systemic eosinophilia. They're often responsive to both inhaled and systemic corticosteroids. They're responsive to inhibitors of type 2 inflammation. And the predominant interleukins on this side are IL-4, IL-5, and IL-13. For non-type 2 asthma or Th2 low asthma, it's often represented by absence of airway and systemic eosinophilia. They may not be, or maybe less responsive to steroids. Currently, we do not have an FDA-approved drug available to manage patients with non-type 2 asthma. And these are the interleukins that are mainly associated with non-type 2 inflammation, such as IL-6, 17, 8, interferon, and TNF. And so these are some of the biomarkers that are currently available for helping manage our patients. Blood eosinophils is easy to get. You can routinely obtain a CBC with a differential count or specifically ask for blood eosinophil counts. It can be used to assess if your patient qualifies for anti-interleukin 5 treatment. And we'll talk about it at a later session. The limitation for this is that fasting, obesity, and adrenal activation can all fluctuate eosinophil counts. It's particularly important that when a patient is on chronic steroids or has been exposed to a recent course of systemic corticosteroids, that may actually mask eosinophil levels and needs to be considered when an eosinophil level is checked. Sputum eosinophils can be checked. These are not routinely checked in clinical practice because techniques are not necessarily standard. They're cumbersome, but certainly there are research studies and protocols that use sputum eosinophils routinely, and they can accurately predict response to inhaled corticosteroids. FeNO, fraction of excreted nitric oxide. These tests are easy to perform. They're often bedside or point of care tests, and they can track closely with sputum or blood eosinophils, and they represent airway eosinophilic inflammation. However, the American Thoracic Society FeNO-guided treatment algorithms have really not helped outperform symptom-guided plans. And then finally, immunoglobulin E. Again, a blood test can be used as a surrogate marker for atopy, and patients with high IgE can be identified to see if they would benefit from treatments such as omalizumab. These levels of IgE decrease with increased age, regardless of the patient's type 2 status, and levels usually poorly predict response rate to omalizumab, and usually we don't necessarily track these patients with IgE once a patient is started on omalizumab. So how do we put all this information together to really personalize the treatment for our patient with severe asthma? So this is the way I approach a patient with severe asthma. We do a dedicated phenotype evaluation, followed by a biomarker evaluation, and then we put the two together. So to review for a phenotype evaluation, you really want to get an appropriate asthma history. How old were they when they first started having asthma? Do they have a strong family history? How's their asthma control? Are they high healthcare utilizers, or is it well controlled? Do they have frequent exacerbations? What is it that triggers their symptoms or exacerbation? Is it allergies? Is it more infections? Is it more exercise? Is it aspirin? What is their exacerbation history? How many steroid bursts they get in the last year? How often have they gone to the emergency room? Have they ever had an intensive care unit admission? And then understanding what their comorbidities are around reflux disease, obesity, sinus disease, sleep apnea, recurrent respiratory tract infections, and then associating all this information with the spirometry. Do they have normal lung function, or do they have obstruction on their pulmonary function test? Do they have fixed obstruction on their pulmonary function test? And then once we know their phenotype, understanding what their biomarkers is to try and understand what is going on in their body and linking it to an endotype or a type of inflammation. And this can be done with the help of an allergy test to see if they have a positive allergy test or allergic asthma, an immunoglobulin E or an eosinophil count check, and a FeNO may be checked as well. So once we have a phenotype and a biomarker, how do we put it together to identify treatments for our patients? So for patients with allergic phenotypes, these are patients who, again, to review from the last session, are early onset. They may develop asthma as a child or as a teen. They're often triggered by allergies, have a seasonal variation to their symptoms, and have a strong family history. For the biomarker evaluation, they will have a positive allergy test or some sort of allergen sensitivity and a high immunoglobulin E level. They may or may not have eosinophilia. And these are the patients who will respond well to omalizumab, which is an anti-IgE monoclonal antibody. For patients with eosinophilic asthma, these are late onset with a lot of comorbidities such as sinus disease, nasal polyposis, and aspirin sensitivity. They tend to have frequent exacerbations and healthcare utilization, and may even require oral corticosteroids for maintenance therapy. These are the patients who an eosinophil would be checked, and if it's elevated, whether it's in the blood or the sputum, would qualify for multiple drugs that are now available by the FDA, such as mepolizumab, breztrizumab, benralizumab, and dupilumab. Again, these are all the drugs that are available for patients with type 2 asthma, and we don't currently have an FDA-approved drug for patients with non-type 2 asthma. Thank you for listening and for your attention, and we'll open this up for Q&A.
All right, thanks everyone. Dr. Jassal, what are our key takeaways from this lecture?
So I think we re-emphasized what we were learning last week, differentiating between phenotype and endotype. Phenotype being those external characteristics that you can pick up on good history and physical examination with some additional findings as well too in terms of spirometry data. The endotype helps you classify the type of eosinophilic, neutrophilic kind of picture, and together they provide a treatment pathway. Be it a medicinal inhaler-based pathway, or if poorly controlled during that pathway, a biologic-based pathway. Now, for kids, like we talked about last week, they're more likely to have type 2 or eosinophilic or allergic asthma. And so with that, we have a regimen that predominantly relies on steroid-based pathways, so inhaled steroid-based paths. And so that gives us somewhat more of an advantage in children, but there definitely are neutrophilic cases, which we talked about a couple last week, especially with the increasing amount of e-cigarette usage in select populations of adolescents, marijuana usage in those adolescent populations, and occasionally, not that as often as seen in the adult population with obese patients as well. The non-type 2 pathway, Dr. Kerr had attributed that to irritants, pollutants, infections as well too. In kids, we can often see those virus presentations, in other words, viral-induced asthma, causing more eosinophilic presentation. Now, there's several mechanisms. There's no one clear-cut mechanism, but we do think that viruses in the pediatric population, at least, can potentiate or exacerbate allergic-based mechanisms. So those are all important to note. And Dr. Kerr had mentioned on 2 occasions during the talk about how we don't have any good available biologic for non-type 2 asthma, which is really important because that neutrophilic asthma is difficult to treat with steroid-based pathways or beta-2 agonist pathways often. There are one good trial in phase 3 work, but right now we don't have any available, so that's really important right now. Now, the other thing too was how she classified Th2 asthma, and I think this went back to a question from last week too, like how do we work these patients up? And what she had mentioned was a couple of good ways to pick up on it. One was just getting blood work, getting a CBC with a differential and looking at the absolute eosinophil count. Some people will use an absolute eosinophil count of 150 cells per cubic millimeter. So depending on your institution, you can kind of figure out where you are in terms of your units. But just in general, 150 cells. So look at that absolute. Don't look at the percent. Look at the absolute. And try to figure out, does this kid have high levels of eosinophils and maybe be a candidate for biologics, assuming good compliance on inhaled steroids? But for me, I like to have at least 300 cells for me to feel a little bit more confident. But the one thing that you have to remember is if you're going to get this, make sure you get it when they're not on steroids, especially the CBC. It is really tricky because unfortunately, we don't see a lot of kids in clinic so much who are really hard to treat. We see them in the hospital. So we feel like, oh, let's just get labs. But the problem is that sometimes our labs are not accurate in those settings that require repeating that lab work. And especially for a difficult to stick kid or a kid who takes blood, in a very, getting blood from them could be kind of traumatic. Something to consider. The other thing she was mentioning was checking airway eosinophils or sputum eosinophils. It's not that simple in kids as opposed to adults. In adults, you can give them a hypertonic saline or a highly concentrated mist to cause them to cough up stuff. In kids, we often get false samples, so I don't rely on that too much. If I'm really desperate on getting an airway cellular count, I'll rather defer to a bronchoscopy because I'm that concerned. But please note, in the world of COVID we live in, nobody should be doing any type of sputum eosinophil checks for the upcoming time period. The other thing she did mention that was excellent was we're checking for the response to steroids. We talked about this last week. It cannot be emphasized enough. I always ask, do you respond to steroids within the first 1 to 2 days? If you do, it does speak to the likely diagnosis of something consistent with an asthma phenotype. Also, I ask for albuterol responsiveness within the first 2 to 20 minutes to also give me a higher likelihood of having that asthma phenotype. And then she also mentioned more specific cytokine-like markers, which we'll get to shortly. But in terms of the biomarkers, we talked about eosinophils, we talked about sputum eosinophils, and then there's exhaled nitric oxide. We're not getting any exhaled nitric oxide, one, again, because we can't do a lot of our lung function testing because of COVID. But in general, exhaled nitric oxide is not something we often do too much. And if you look at the updated, so December 2020 NIH guidelines, the NIH is saying that it is recommended in very specific circumstances. So it is meant for those as a diagnostic or perhaps a management pathway on existing things. So it's not your first go-to. Is if you're not quite sure of the diagnosis, if you're not quite sure of the management, maybe it has a role in those greater than 5 years of age. But in general, it's not something we should jump to. And then the total IgE. But for me, what I like to do in clinic is I always get for anyone with moderate to severe asthma on the first visit, or I talk about on the first visit so they don't get all frightened that I'm gonna get blood right away, is a CBC with a differential, a total IgE, an aspergillus antibody, and then the allergen testing as well too. And then Dr. Kerr had finished off the talk talking about that phenotypic evaluation, like what do we get from a history? And I'm not gonna repeat everything from that. There are two things that I wanna emphasize is one, when you look at the healthcare utilization, pay attention to the need for non-invasive and invasive ventilations. Too often we have ingrained in our head, we ask, oh, have you been intubated? Okay, and then we move on to the next one. But not being intubated and requiring non-invasive forms of ventilation like BiPAP is important. It is a major criteria saying that this is a high-risk kid and we need to do more for them and we need to pay closer attention to them. So that's one thing I would emphasize in that. And the other thing too with the phenotypic evaluation, and it goes with the virus issue, is the early viral exposure. So especially for my young kids where the moms are more attuned to the recent history, I'll ask if they've had a recent viral exposure, or more importantly, they have an early life exposure that made them more likely to have wheezing and or asthma later on in life. Classically, we think of RSV, right? That got all the attention. But the one that is getting a lot more attention is rhinovirus. Who knows about with the current landscape what that's going to look like. But we do know that early life exposures to these cold illnesses can set up the right patient. So genotype, genetics and environment, so we're talking phenotype again, can set you up for a later on in life asthma exposure. And then I think she finalized the talk on the biologics, which we're going to get to next week, I believe. So we'll talk about that more in detail next week, but everything in biologics is oriented to that type 2 pathway, which benefits us in the world of pediatrics so far, but there are these newer neutrophilic ones that are in phase 3 testing that will help the low eosinophilic types of patients, which we do have a decent amount of, that'll really help them going forward in the future.
Thank you so much, Dr. Jassal. Do we have any questions from the group about the lecture or Dr. Jassal's points?
You know, I was going to say one thing in our asthma home visit program when we're working with people is, you know, trying to get them to someone like Dr. Jassal. And sometimes they think, oh, well, I can't leave my pediatrician. And we'll explain to them it's okay to have a specialist and a pediatrician. Your child's still going to need stitches and have strep throat and need their school physical and that type of thing. But there comes a point where you really do need to go to a specialist and make sure that you get this managed, because I love, love, love pediatricians. And honestly, I don't know how they do it. It's like being a detective, and hats off to them and primary care doctors as well. But if there is something like this, that someone is really struggling, you've got a child that's struggling and they're not being managed and you're not quite sure what to do, it's perfectly fine to have them go to a specialist. And I think my specialist just about raised my kids. It's been 21 years he's been treating our kids. So for what it's worth, making sure that they have that specialized care when it comes to asthma, and they can still keep their primary care doctor or pediatrician for other needs as well. But it can be a little bit tricky trying to get people to understand that.
Andrea, you bring up a really good point about the need for referral at a good stage. If you look simply at the GINA guidelines, you're going to see the comment about referral to an asthma specialist right at the end of that table. So you have to go to the extreme to having the most severe asthma, and that's when you're seeing us. And the updated NIH guidelines, and I think they've done a really good job on this component, is saying it should be earlier, like around that stage 4-ish type of period. So when you have moderate asthma, or you think you're on a moderate controlled form of an inhaled steroid, it should be at that point you should be referring to us, because this is pretty tricky in terms of trying to manage that level of severity. I think pediatricians can do it in certain components, and I definitely believe they can do it. But with everything they got going on in 20 minutes or 15 minutes in our crazy healthcare world we live in, sometimes it's difficult. But with that being said, I think anyone with moderate asthma should be considered, should be a candidate at least for a referral to an asthma specialist. With that being said, there's a lot of people probably maybe there's some people on this call in which the asthma specialist may be hours away. So it might not be as easy to refer to people like me because the families don't want to. And what I would say is, mentioning it like we talked about in Dr. Care's last two talks, is about getting that good history and physical, and getting a good cemented phenotype, endotype, to figure out what you're dealing with, and then getting the right regimen is really important. And I think that's probably one of the biggest things that I could give as a takeaway, is finding out the right regimen and making sure you stay compliant on that. And that's where you and me, I think, Andrew, we work really well together, and we complement each other really well in representing the home experience and the clinic experience, and coming together as good as possible.
Right. And that's another thing we really focus on, is having them give that feedback to you or to their primary care doctor, whoever they're seeing, about how to know when their asthma is controlled and it's not well controlled. And so I obviously don't practice outside my scope of experience, but we need to make sure, if you don't give any feedback to your doctor, he's going to assume that you're doing really well and that that's a great biologic for you, or that's a great inhaler. And so if he doesn't hear back, then that's where you're going to stay. So let him know if you're using your albuterol more often than you normally do. Let him know if you're ending up back in the hospital, all that. They need that feedback. And I said, let's do this team approach. And so it's really working to do that team approach with the patients. And I know it's hard, and I know we're all exhausted, and I know COVID's a nightmare on top of everything else, but yes, we're here to help any way we can.
Excellent. Thank you both. Any questions or thoughts from the group? All right, excellent. Well, I think now is a great time for us to switch over to our patient case. Today, this will be presented by Dr. Jassal. Alrighty, Mandeep, take it away.
So we have a 15-year-old adolescent Hispanic female who was born full term, no NICU requirements, no oxygen requirements, and developed what we think is consistent with asthma at approximately 6 to 8 years of age, so a little bit later in life. Unknown viral triggers, but the symptoms consist of cough, expiratory wheezing, and shortness of breath. Albuterol does help, but not always. Prednisone does help, but she says that it takes up to 2 to 3 days to really show an effect. She does have upper respiratory tract infections as a potential trigger, outdoor allergens as well too. She says she's had past testing for environmental allergens, but they didn't bring in the results on their first visit, and they don't really recall everything. She also said that she does have past testing that's positive, so some indoor allergens, once again, doesn't know, and no food allergies, at least being reported. She says exercise is definitely a trigger, and emotion, specifically anger, excitement, and laughing are triggers. Now she uses Symbicort, 2 puffs twice a day, and when referred to us, she also is using Symbicort as her reliever therapy, as 2 puffs as needed. Singular was used as 1 tablet a night, so at least 3 controller medications. And then as far as her asthma, past regimens, that has included high-dose Flovent. It has included Symbicort at different dosages, along with Advair as well too, at a higher dose. There is no concerns for medication adherence as per the family, but when we look deeper in the refill history and the electronic health records, it does look like there's some missed fills. She's had 4 hospitalizations over her lifetime, 1 of which required intensive care, no intubation requirements, no BiPAP and or non-invasive ventilation requirements. She's had 5 ED visits in the past year, so this year has been a traumatic one for her, and has had 5 steroid courses, all corresponding to those ED hospitalizations. And her last asthma control test was poor at 7, approximately 1 month ago. No other significant past history. There is a strong family history of asthma, but no other significant disease, no infectious disease history on review of symptoms. I mentioned the allergy history earlier, but no history of anaphylaxis. We do know that on that first visit, she did mention that past asthma care was provided by another healthcare provider, but unfortunately we didn't have those records at our initial visits. But all they kept saying was, we think she's allergic to everything. A negative cardiology past history. She does report some chest discomfort with eating some spicy meals, and she is obese. She does snore at night. She has been witnessed by her mother to have apneic-like events. She did have a sleep study done in the past. It had an apnea-hypopnea index of 30.2 events per hour, so demonstrating severe sleep apnea. Mom reports that, however, she is not compliant with her prescribed use of BiPAP. She has been evaluated by ENT, so she has had an adenotonsillectomy as a toddler. So that sleep study that showed the severe OSA was done well after those adenoids and tonsils were taken out. Ventilate, no, it doesn't have any baseline ventilation requirements other than the BiPAP requirements. Negative rheumatologic history. Oh, and mild to moderate eczema as well too. Negative neurologic, and then from a behavior standpoint, there's no formal psychiatric diagnoses that we could find in the medical records that were available, or any ongoing consultations. But the family has reported that she has been being bullied in school and has missed several missed days of school for reported asthma symptoms. And I write that in quotations, and I hope that we'll have some more questions in regards to that. And then as far as non-pulmonary medication, she's on Zyrtec once a day. Does take some herbal supplements too. Biomarker-wise, she has an absolute eosinophil count of 310 cells per cubic millimeter. There was a blood gas acquired at a recent hospitalization, just because of O2 requirements, not typically something we do. It wasn't too concerning, just a slightly elevated CO2, but nothing to get overly concerned about. Her total IgE was quite high at 1850. There was no aspergillus antibodies. No, there wasn't any elevated inflammatory markers, negative rheumatologic screen. And her vitamin D level looked to be okay. She had quite a bit of allergies around the board in terms of environmental concerns. We did not screen, or I did not report the food allergy screens, but those also did not show anything significant. From a diagnostic standpoint, she had lung function testing and it showed a combined moderate restrictive and obstructive ventilatory defect. Because of that restrictive component, we wanted to make sure, were we missing something else? Was there something besides asthma going on? So we got complete lung function testing. And what it showed was that she has a lot of air trapping, but this time around she had a normal total lung capacity. So that restriction that we're seeing probably was just a lot of air trapping that had prevented her from opening her lungs sufficiently. The chest x-ray showed a lot of bronchial wall thickening, but no focal abnormalities. And I already talked to you about the sleep study. So her weight is well above the 99th percentile. On exam, she has inspiratory wheezing noted over her glottis. She has expiratory wheezing as well that's heard over the lung lobes. So my key questions for this adolescent female with what seems to be severe asthma based on the frequency of presentations of disease, the need for systemic steroids, however, has notable issues with compliance, has severe OSA with notable issues with BiPAP. The things seem like they're worsening over this past year with potentially behavioral contributions. And a very notable exam that I mentioned, not only in terms of the weight, but in terms of the location of the wheezing. Would this asthma phenotype indicate that she's a candidate for biologics? And which one would you start, if you would start any at all? And how would you address the poor compliance for asthma control and the BiPAP usage? And I mentioned about the inspiratory wheezing and how that could influence your diagnosis and your management of asthma. If anything, that should be moved up to number 1 and the rest to number 2 and 3.
I think everyone's still processing because there's so much there.
Yeah.
That poor girl, wow. This would be a really tough one. Where do we even start? And I'm looking at the inspiratory wheezing. And for me, I would be thinking, is there vocal cord dysfunction going on along with asthma? And I can see someone put in the chat, absolutely. I think counseling is very big. It's hard being a teenager. And I think being bullied and being with her weight, and along with that is all those courses of oral steroids she's going to be packing on the pounds. And that happened to my son that's 26 now. When he was in high school, that same thing happened because he was in the hospital so many times, and every time he'd have to do a course of steroids. And I will try to find, and I can send this to Ashley if I can find, I made a graphic from a webinar that I saw, and someone was talking about using a fire extinguisher. If you were in your home and you kept having these little fires popping up and you just pull out the fire extinguisher and just, put it out and then go on with your life, well, wouldn't you want to find out what's causing that fire? And so it's the same thing with asthma. Do you want to keep using your little rescue inhaler, or is there something else going on? And there's also looking at how many days that she could use her Symbicort versus one burst of the steroids. She's getting a lot more medication with that systemic steroid and swallowing that and having it go through her lungs and kidneys and everything else. And she's a kid. She needs to be laughing. She needs to be having fun with her friends and not being held back and not being able to laugh and cry and all those other things. And then also looking at hormones, we know that hormones, lucky us, all of us women, can play a fun role with asthma. And some women even have flare-ups once a month when it's that time in their cycles. So, wow, this poor kid. It's no wonder she's struggling. And we know that there's a correlation with asthma and depression as well. And that would play into the bullying that's going on. So a lot of things to unpack here.
Mandeep, would you like me to reiterate the question and the questions in the chat so everyone can see? I know it's tough when we read them out, but we don't have it still up for you. That's mostly because at this stage, we like to see everyone so that you can all talk to each other.
Yeah, absolutely. Maybe that would be helpful.
Excellent.
I think while we're doing that, Andrea broke down how complex this patient is. And I think what we can do is we can maybe address the questions that we pose in the context of the complexities of this patient. So dealing with the inspiratory wheezing and the concerns for vocal cord dysfunction. And I think that probably is the one thing that we can talk about right away is how to treat the vocal cord dysfunction, which we know, or we think that it can be anywhere from 10 to 15, even all the way up to 30 to 35% of patients who have VCD or vocal cord dysfunction or vocal cord disorder, however you want to describe it, and having asthma symptoms at the same time period. So we have to treat both. So I guess the first thing that I would be interested to know is what the group thought about that inspiratory wheezing and the potential workup, or how they want to go about it, or just let it be at this point.
I also had a question, and sorry to do all the talking here. I know our group's a little bit quiet. I think we're all tired. Just wondering also about the obesity, and is she reluctant to do any sort of walking the dog around the block or going out with her friends because of the vocal cord dysfunction? And that's something that my daughter experienced as well. She's 21 now, but she really struggled. So we actually did speech therapy with her, and she had to learn, a new way to breathe and her different exercises. And so she could tell the difference between which one's vocal cord dysfunction when it's her asthma. And as a student athlete, it was really difficult for her. But letting this poor girl know it's not you. Here's what's going on, and here's how we can help you with this. Let's give you a really good quality of life because you're still young. You need to have fun with your friends and enjoy life. And let's help, see what we can do to help you get there.
Yeah, you bring up a really good point in terms of trying to understand the impact it has on one's personal life. So those patient outcomes are pretty important. And so we need to acknowledge that. And so because of her, the emotion-related triggers that she reported, if you remember that as part of the history taking, it has altered how she approaches her friendships. She won't laugh as much, or she'll try to keep her emotions as much in check as possible. I also noticed that in the chat box, there had been some points mentioned whereby you definitely would try to control the inspiratory wheezing, and then issues about compliance as well too. And then issues about relaxation breathing with wheezing as well too. I'm going to get to the wheezing, then we could return back to those other points as well, which are very important. So to get to the relaxation breathing and VCD, so to diagnose VCD, there's no great way. Although it would be awesome if I had a great technique in the clinic setting. Sometimes I'll have, especially for the athletes, if they're ready to do a treadmill test, I'll have them do flow volume loops or spirometry while they're exercising, so I can see that problem on inspiration in their loops. Sometimes I can get them running up and down in a treadmill or around the parking lot a little bit to get them really going, so I can hear it myself. But more often than not, I'm not so lucky. But there is some okay screening tools. So for those who have the ability to download, the Pittsburgh Vocal Cord Dysfunction Index, so the Pittsburgh VCD Index is a 4-question tool looking at throat tightness, sensitivity to odors, dysphonia, and absence of wheezing. And if you get a score of 4 or more, so if you have throat tightness, that's a score of 4 right there. It has a pretty high predictive ability to diagnose VCD. I think if it's 4 or more, it gives you an 80% sensitivity, and I think it's close to a 90+% specificity. So it's a pretty good test. And then speaking to the point that was brought up about relaxation breathing, absolutely. So I, by no means am I an expert. I'll often refer to speech therapy, but because I don't want to overwhelm speech therapy with a lot of these cases, of which I'm seeing a lot amongst adolescent females, especially in the context of this COVID issues, because a lot of kids are staying at home, a lot of kids are in stressful environments with their parents or with other kids or just by themselves, and really putting themselves under a lot of emotional strain. So I recommend diaphragmatic breathing. I'll teach them how to do it, either in a video visit or in the office. You guys can do this, simple stuff you can see. But one of the biggest things that I use for relaxation breathing is I tell people, don't rely on your mouth to breathe. Rely on the combination of nasal and mouth breathing together, or nasal breathing alone, to help you overcome this. So I'll often have them breathe in through their nose twice or out through pursed lips. Pursed lip breathing that we think about for COPD patients can be helpful. Sometimes the nasal sniff technique where you go can also be very helpful while you kind of keep on doing that. That can help a lot of the VCD symptoms, but some of it comes down to speech therapy. You also have to be worried about other upper airway pathologies like reflux, but that's not going to be as likely in the pediatric population. There was another thing in the chat box we could get to about compliance, and it was mentioned on 2 points, one about compliance and the other if the insurance will pay for biologics, given considering the compliance history. And spot on for the person who said that, because it is such a challenging thing trying to get biologics for a lot of my kids, mainly because compliance is a major issue. Because sometimes you need, depending on your insurance, 80% compliance over 6 months, which is really, really hard for some families in terms of refills. So, but with that being said, it is important. I don't have any major strategy other than to say that I do give monthly calls to my more severe patients. I've been, with the help of video visits, been able to check in with them more often than I typically had done in the past. So a benefit of COVID, but I am on top of the ones who are non-compliant. But with that being said, I've been trying to alter the medication regimens to make it easier on them as well. So one strategy that I think you're going to find a lot about going forward, we're going to hear a lot about going forward, starting this year and more going forward, are these SMART regimens, where it's a single maintenance and rescue therapy in one. So Symbicort is the one that's been most often referenced, and it's been referenced in the GINA guidelines that Dr. Kerr had mentioned in her video, and it's being mentioned more in the NIH guidelines as well. So your Symbicort is your controller, so 2 puffs twice a day, and the Symbicort is your reliever. How many puffs do you give? Well, you would say, all right, take your Symbicort 1 to 2 puffs in the morning, and then you'll take it as needed, but you're going to take no more than 12 puffs per day if you're greater than 12 years of age. If you're between 6 to 11, well, you're going to reduce that down to around 8 puffs a day. But to give you, it is very hard to teach families that. So for the participants on this call, it's a challenging thing to teach families a new way of thinking. But that is the challenge, we as the pediatric community are posing to you as the practitioners who are more closer to the vast majority of asthmatics than myself. But I think that's where I believe you guys can do it, because for our non-compliant patients, who we think are not taking anyway their inhaled steroid most often, right? And then when they have an illness, they rely on albuterol. So the one thing that can only give them temporary relief, that's what they're using when they're most sick. Why wouldn't we use the controller and the reliever at the same time to give them the inhaled steroid at least during those moments? How often they usually require them is usually about a day or two is most is what they need. So the regimen that this kid on the one that came in on that we talked about, just the twice a day is needed, wasn't enough Symbicort. So we'll talk about what we eventually did for this kid on multiple fronts, but one way to control the asthma is we put them on a SMART regimen to make it easier for them, because we knew they needed a daily medication, but we tried to boost it up. And know that going forward for the practitioners on this call, before you jump up, before you step up to a higher steroid, to more medicines, think about changing up the LABA ICS or the Symbicort or some equivalent, and use that as your rescue medication before you jump up. And then the biologic mentioned as well too. Yeah, that's before we jump to the biologics, we always want to consider the compliance issues that I wanted to talk about earlier. Oh, and then Nina mentioned a really great question, a really good point. As a school nurse, having the daily medications done at school, and Andrea can speak to this as well too to help with compliance. There are good studies. I think we talked about some of this before. Good work done out of the University of Rochester, most notably. Other institutions have done good work, but I think Rochester deserves the most amount of credit on this front. And talking about school-based forms of therapy, whereby you're getting it once a day, but at least you're getting it once a day. And you might only get it Monday through Friday, but at least you're getting it. And what they're found is it seems to be successful. So if you have a school-based system, and it's tricky, and I'll be interested in Nina what your thoughts are on this, but it would be quite helpful.
With patients that I see struggling and I often see in my office, I'll offer that to parent and physician, and we've done it in several occasions and it is better. So some physicians or some parents do not want it, they refuse it. The student continues to struggle. So we're always willing, like our school is 9 a.m. to 4 p.m. So definitely I can give it once a day, maybe even twice, depending on the medication. But I do see that students do really well. We make sure they get it on time, and we're teaching them at the same time to do it. So it's good. And I see improvement.
Thank you, Nina. And I just want to sort of read out a little bit of what's happening in the chat. Shannon mentioned that with COVID, many students are at home. And Martha said, even while having school at home, teacher, nurse could prompt the online students or have some sort of, nursing communication with the students. So I'd be interested to know if anybody has seen anything quite like that. Sounds like a great quality improvement program.
Yeah, it does. It's a great idea. I didn't think about that. Patrick also asked a question, if I could address it. Could a diet to lose weight along with psychotherapy modify the course of her health problems? Yeah, Patrick, I think it probably could help. So what we're seeing a lot is the link between obesity and asthma. So we have seen pretty good data to show that there's a higher incidence of asthma in those with lean BMIs versus those with obese, or those classified with an obese BMI. So given the higher incidence in those populations, we think there's a link. Now there's many speculations about why. Some people have attributed cytokine hormones like leptin levels being associated with hyper-responsiveness. Leptin being like that very popular type cytokine hormone that's been discussed lately. The other thing too that makes obese patients more likely to have asthma, if you think about it from a lung function standpoint, those with abdominal forms of obesity, if their airway is open like this, if the person who's obese has what we call functional residual capacity or lower resting lung volume. So instead of resting like this, it rests more like that. So when it inflames, you're more likely to close.
Uh-oh, I think that we have frozen Dr. Jassal. Oh, you just came back.
Oh, sorry.
Nope, we got you.
Connection at Hopkins.
It happened.
I know, this is terrible. It's this institutional-based internet. But the two components of obesity that has been focused quite a bit on is the Mediterranean diet. And I know that there will be a lot of people on this call to almost roll their eyes at me and say, come on, a Mediterranean diet in select inner city settings is easier said than done. But this is what's been studied, and it's probably been studied on many other disease processes given its antioxidant and anti-inflammatory pathways. But as far as a public health campaign, maybe that's a good push for a reason for healthier diets for kids. And bariatric surgery, which I would not recommend unless, in the most severe cases. But BiPAP compliance is really important. So I pull monthly reports for everyone who needs BiPAP or CPAP for their OSA. And I try to encourage them to use it and I usually involve like home care individuals to help me remind them to use it. And then the psychotherapy, absolutely. Getting a person involved in psychological care is really important. And often for me in my institution, speech therapy and psychotherapy often go hand in hand, especially for a more severe vocal cord dysfunction or severe asthmatics.
Thank you. Alrighty, so thank you everyone for a wonderful discussion in the chat and with us directly. I want us to sort of scoot on. We've got this last 5 minutes left. So I was wondering, Mandeep, would you let us know what was the outcome? Where are we currently with your patient?
Yeah, so in terms of breaking her down to dealing with the severe asthma, because she was not compliant on her medication regimen, we could not get the insurance to allow us to give us once daily forms of therapy, things that could be helpful like Brio or Annuity. So we relied on the SMART form of therapy, to give us a better sense of, or give her a better chance of getting under control, knowing that she's probably not going to take her medication on her own. So we relied on Symbicort, high-dose Symbicort twice a day, and then Symbicort as needed up to the maximum of 12 puffs a day. Then for the OSA, we re-emphasized the need for BiPAP, pulling monthly compliance reports. Things, and I'll get to this shortly, have not improved too much, but we're working on it, work in progress. And then for the VCD, we did teach her some exercises and things seem to be better on that front, but her asthma, interestingly enough, has gotten under better control during this COVID period. The reason is she is not in school. And by being not in school, we've removed that one environmental trigger that is not pollution or smoke or anything like that. It is the kids and the bullying. And by removing her in those environments, her asthma is under better control. And I recently saw her, the family, despite the improved level of asthma control, and we already talked about weaning down to a lower dose form of inhaled steroid therapy to minimize some of the steroid related effects that Andrea had mentioned as well too earlier. The family does not want to send her back to school, knowing how well she's now doing outside of the school environment. So different things and different times.
All right. And thank you, everyone. We're going to, homeschooling does sound like a good option. Imagine that different modalities for different people. Shocking. Alrighty, so we'll get started with our post-test polling questions and get everyone out hopefully on time to continue their day. And now for our knowledge questions. Question 1. Which of the following is the definition of an endotype? The external observable characteristic of an organism resulting from interaction between its genetic makeup and environmental influences, or a distinct biological mechanism that is underlying a distinct disease entity. Or question 2, which of the following is not a biomarker for type 2 inflammation in asthma? Immunoglobulin E, IgE, eosinophil count, fractional exhaled NO, FeNO, or interleukin 17. Okay, Mandeep, how'd they do?
Everyone did really well. Which of the following is the definition of an endotype? It is the biologic mechanism, so it tells us the eosinophilic, the neutrophilic processes, while the phenotype is the external characteristics, the things we can gather through history, physical, lung function testing. And then the second question is, which of the following is not a biomarker for type 2 inflammation? And the group as a whole got it right in terms of IL-17. IgE, eosinophils, FeNO, all speak to allergic or type 2 inflammation.
Thanks so much. Thank you everyone for answering those. Alrighty, we are at the end of our time, and as usual, I always just want to ask if anyone has a patient case that they would like to discuss for next week. Anyone who's actively seeing patients, or you had a patient in the past who stumped you. We'd love to chat about it. Alrighty, well, thank you all so much for joining us this afternoon. We've got another wonderful lecture next week. This is going to be a slightly longer one. We're going to talk about biologic treatment options, everyone's favorite, next week. And we look forward to seeing all of you. So thanks everyone for being here. We'll see you soon. Bye-bye.